Welcome back to the deep dive. Today, we are strapping in for a really high-stakes, rapid-fire exploration into a major crisis in cardiovascular medicine,
A really immediate one.
acute decompensation in heart failure, or ADHF, as we'll call it.
Right. And this isn't just a review. Our sources today are, I think, laser focused on a clinical reality that can get missed.
Okay.
That ADHF isn't just one big condition. It's not a monolith. It actually presents as four very distinct, very critical syndromes. And the second a clinician figures out which one they're facing, well, the whole treatment strategy has to shift.
So the mission for us today is clear. We need to synthesize this, recognize these four presentations, and this is the key part, understand the specific customized interventions for each one.
Exactly, because in this world, the difference between a life-saving drug and one that's actually harmful can just hinge on getting that initial profile right.
It's all about moving past that generic diagnosis then.
Yes. And getting to the actual mechanism of the crisis. We're looking for that heterogeneity, where small differences in how a patient presents demand these dramatically different approaches.
Okay, so let's unpack this clinical puzzle. We'll start with what our sources are calling the typical acute decompensation.
The most common one you'll see.
But even here, you're saying there are two distinct paths, and they're determined by something pretty fundamental.
That's right. It all comes down to volume status versus pressure.
So this is the core distinction you have to make right at the start.
It is. You have to differentiate between a patient whose crisis is being driven by, say, sky-high blood pressure versus a patient whose crisis is really just about pure fluid overload, even if they both, on the surface, look like acute heart failure.
So let's take that first path. The hypertensive ADHF, what's the profile there?
So this patient is, they're in acute distress, but the defining feature is that high blood pressure.
Okay.
And crucially, in this presentation, they're usually not severely volume overloaded. The pressure itself is what's precipitating the whole thing.
So if the problem is pressure, then the primary management principle has to be?
You have to open up the plumbing immediately. So the primary treatment is vasodilators.
Right.
We want drugs that relax the blood vessels, rapidly reduce that resistance the heart is fighting against. It just dramatically decreases the strain.
And that often resolves things faster than just trying to pull off fluid.
Much faster.
That feels intuitive. High pressure, use pressure-reducing agents. Okay, so now let's flip to the other side of this typical coin, the normotensive ADHF.
Right. So here the patient has normal or near normal blood pressure, but they are absolutely flooded. The normotensive presentation is generally characterized by being usually volume overloaded.
So they're drowning in their own congestion.
Pretty much. The primary problem here is all about fluid accumulation. So the focus has to shift completely away from pressure management.
And to what?
Diuretics. The primary treatment principle shifts entirely. We've got to get that excess volume off and fast to relieve the congestion in the lungs and, the rest of the body.
This is a major aha moment for anyone listening, I think.
It should be.
Because you've got two patients, both with acute heart failure. One gets vasodilators for high pressure. The other gets high-dose diuretics for high volume, even with a totally normal blood pressure reading.
And this is precisely where management errors can happen.
How so?
Well, if you mistake that hypertensive patient for a simple volume issue, and you just hammer them with diuretics when they aren't actually that overloaded,
You could cause problems.
you could cause an acute kidney injury, or you might even worsen their vasoconstriction, which just makes the heart work harder. Misdiagnosing that pressure volume status, it just undermines the entire treatment right from the get-go.
Okay, so we've set the baseline for typical. But the source material also flags something else that's essential.
The high-risk features.
Right. And these mean that no matter if they're hypertensive or normotensive, the situation can escalate at, lightning speed.
Think of them as just giant red flags waving frantically. We can sort of group them into two buckets.
Which are?
Immediate cardiac insults on one hand and pre-existing organ stress on the other.
Let's start with those immediate insults. What are we looking for?
We have to be looking for acute coronary syndrome, or ACS. Are they having a heart attack right now?
Okay.
Or a sudden new onset arrhythmia, which could totally destabilize their rhythm. Also, any signs of hypoxia or a potential pulmonary embolism, a PE.
A blood clot in the lung.
Exactly, which puts severe strain on the heart.
And then what about that other bucket, the underlying organ stress?
These are the signs of a more systemic breakdown. So existing or worsening renal insufficiency, which means the kidneys just aren't clearing fluid.
Right.
Elevated biomarkers of injury telling you there's tissue damage happening.
Yeah.
And you can never forget infection. An underlying infection can easily push a stable heart failure patient right over the edge.
That really sets the stage for a rapid escalation. So let's transition now pretty sharply to something more immediately threatening than even typical ADHF.
We're moving into a severe acute congestion crisis.
This is the second syndrome, pulmonary edema.
And this is a true life or death scenario. The patient is in extremis.
So what's the key clinical feature here?
It's severe pulmonary congestion combined with acute hypoxia, and critically, a state of extreme distress.
So these are the patients you see sitting bolt upright, gasping for breath.
Yes, sometimes even frothing at the mouth. It's that bad.
The suddenness of it all suggests there must be an acute trigger. What does the source material list as the precipitating factors?
So a lot of things can cause this flash flood in the lungs. A new arrhythmia, severe structural problems like valvular heart disease or VHD,
Okay.
acute myocardial ischemia, inflammatory heart disease, even a neurological event like a CNS injury or sudden drug toxicity. It's all about pressure building so fast the lungs just can't cope.
So given that severity, the management has to be immediate and aggressive.
It's a multi-pronged assault on the crisis, really.
So how do you approach it? What's the rapid management strategy?
You have 3 goals at once: support breathing, reduce anxiety, and crash the pressures down.
Okay, so first things first.
First is immediate O2 and non-invasive ventilation. It's essential. You have to force oxygen across that fluid barrier in the lungs.
And at the same time, you're going after the cause of the pressure.
Exactly. You hit them hard with high-dose AV vasodilators. You want to instantly lower that resistance in the vessels, which reduces the back pressure into the lungs.
And diuretics.
And, because there's usually a massive volume shift involved, you start diuretics to begin clearing that fluid out.
Now, the sources mention something interesting here, a slightly older tool that's still listed in the approach for this level of distress.
Opiates.
Yes, the use of opiates. Why is that inclusion notable?
It's important because it addresses the whole picture. The use of opiates here is sort of dual purpose. They help reduce the patient's extreme anxiety and panic, which lowers their adrenaline response.
And that reduces oxygen consumption.
It does. And on top of that, they also have some mild vasodilatory effects, which helps manage venous return. It just supports that primary goal of relieving pressure and congestion in this incredibly unstable patient.
So that moves us from a problem of volume and pressure into a crisis of flow. We're shifting focus entirely now.
Right, away from congestion.
To the third syndrome, low output syndrome. This is all about systemic hypoperfusion.
Exactly. If the first 2 syndromes are about the plumbing bursting because the pressure is too high,
Then this one is about the pump sputtering.
sputtering and starving the system. The clinical manifestations are defined as hypoperfusion with end organ dysfunction.
So how does the body actually signal this lack of flow to us on the outside?
We look for specific physical signs that blood just isn't making it to the extremities or the internal organs efficiently.
Such as?
A low pulse pressure. So the difference between the systolic and diastolic numbers is really small and critically cool extremity.
Right. The body is rationing blood flow.
It's pulling it away from the skin and limbs to try and protect the core.
And when that rationing happens, the systemic complications must be severe, especially for organs like the kidneys and the liver.
Absolutely. That lack of forward flow causes immediate distress. It leads directly to things like cardiorenal syndrome, where the heart failure is causing acute kidney failure,
And the liver.
and hepatic congestion, where blood just backs up into the liver. It can't get through.
So the treatment pathway for low output has to look very different. You have to support the circulation, not just depressure it.
That is the absolute crux of it. We might, start with cautious vasodilators if their blood pressure is still high enough to try and reduce afterload.
But there's a major escalation point here.
There is. If the patient has low blood pressure, or if they're just not responding to diuretics because their circulation is too sluggish, we have to introduce inotropic therapy.
Okay, let's just clarify that for everyone listening. What does an inotrope actually do?
An inotrope is essentially a drug that strengthens the heart's contraction. It's like putting high-octane fuel into that failing heart muscle, just trying to squeeze more blood out with every single beat.
But that sounds like you're walking a tightrope.
You are. These drugs can increase the heart's oxygen demand, and they can sometimes trigger arrhythmias. It's a very fine balance.
Which means if that initial pharmacological push isn't working, you have to bring in the big guns of surveillance.
Precisely. The need for aggressive hemodynamic monitoring is specifically indicated if there's a suboptimal response. We have to move past non-invasive monitoring
Why is that?
because we need precise moment-to-moment readings of the internal pressures and flows inside the heart to guide the exact dose of those powerful inotropes. You're balancing the heart's workload against the body's perfusion needs in real time.
That level of intense monitoring, it brings us to the most critical syndrome, the final stage where the system has just reached a catastrophic failure state.
Cardiogenic shock.
This is the culmination of everything. Low output, end organ failure. It's the profound end stage of decompensation.
It really is.
So summarize the devastating clinical picture for us here.
The patient has this trifecta of failure. You have hypotension, so extremely low blood pressure. You have low cardiac output, the pump is failing, and you have systemic, widespread end organ failure.
So you see extreme distress.
Severe pulmonary congestion, acute renal failure, a rapidly deteriorating level of consciousness. The whole system is shutting down.
So given that the body's own systems are failing so utterly, the interventions must be the most aggressive and advanced ones we have.
They have to be. Initially, we're relying on highly potent pharmacological support, meaning high-dose inotropic therapy, usually specific agents we call catecholamines, just to try and maintain blood pressure and vital organ function by sheer pharmacological force.
But when that last burst of fuel isn't enough to keep the engine running, we have to move into a truly invasive mechanical support.
Yes. When drug therapy fails to maintain adequate perfusion, mechanical circulatory support becomes essential. This is really the last line of defense, and the source material emphasizes specialized devices for this.
What are some of those specific devices?
Well, we're talking about things like the IABP, the intra-aortic balloon pump. It's a timing device that inflates and deflates to help the heart's pumping action.
And then there are more advanced options.
Then you have percutaneous VADs, ventricular assist devices. These are basically miniature external pumps that can take over the work of the failing ventricle entirely.
And for fluid.
And if fluid is that final limiting factor, we use ultrafiltration to mechanically pull off massive amounts of fluid very quickly.
It connects all the dots perfectly. In cardiogenic shock, the heart simply can't sustain life anymore.
It can't.
So you need external, mechanical, or incredibly potent pharmacological support just to maintain blood pressure and oxygen delivery.
The pump is structurally failing, so you have to reroute the blood flow externally just to buy that patient more time.
This has been a really critical deep dive. The core insight we've established is that ADHF demands highly customized treatment.
Absolutely.
The clinical team has to accurately diagnose which of these syndromes, whether it's hypertensive, normotensive, pulmonary edema, low output, full-blown cardiogenic shock, which one the patient is actually presenting with.
Because the intervention you need ranges from, some mild diuretics in a congested patient all the way to heavy-duty vasodilators and then up to these specialized mechanical bypass devices.